attend this session. My goal is that by the end of this session, I wanted to build a very strong foundation for you guys, enough for you to get every single question right on exam day and to get 3 points, basically. My name is Chams Albachir, and I'm very happy and excited to guide you through this topic. I've also added my contact details for you guys if you had any questions at any time. So by the end of this session, you guys should be able to read an ECG. You should be able to differentiate between a normal and an abnormal ECG. And you guys should be able to give diagnosis to very few pathologies that you should know at your level. And then lastly, we'll end this session by a bunch of practice questions that would be very helpful to reinforce this idea or the information, any new information that you guys learn during this topic. So starting off, first of all, with the basics of ECG. Now, the first question that comes to your mind is, what is an ECG? And ECG is basically defined as, it's an abbreviation for an electrocardiogram. So electrocardiogram, electro for electrical activity, cardio for the heart, and then gram for a recording. So it's basically a recording of the heart's electrical activity. The next question that you should be asking is, why do we need to know what's going on with the electrical activity of the heart? Like, how would this help us and what would it tell us exactly? And to be able to answer this, we would have to go back to the normal function of the heart. So I'll just quickly recap this because Rawad, mashallah, already covered this very well. So first of all, starting off with the heart and how the blood flow goes through it. So it all starts with basically the lungs. Let's take the lungs. In the lungs, the main function of the lungs is to oxygenate the blood, which basically means adding oxygen to the blood. And then the blood comes back from the lungs into the pulmonary veins, into the left atrium. So the left atrium then contracts, pushing blood into the left ventricle. And as soon as the left ventricle is filled up, it contracts, pushing the blood into the aorta, which then takes the blood to the rest of the body, where it distributes this oxygen to the tissues. And then when the tissues take the oxygen that they need, the blood comes back as deoxygenated, which basically means that it no longer has the same amount of oxygen that it used to have. Now, after the blood comes back, it comes through the venous system, and it goes through the vena cavas, the superior and inferior vena cavas, and it collects in the right atrium. When the right atrium is filled up, it contracts, pushing the blood into the right ventricle. And as soon as the right ventricle is filled up with this deoxygenated blood, it sends it back through the pulmonary artery to the lungs to get oxygenated. So we can divide the heart into two parts. There's the right side of the heart and the left side of the heart. Right side of the heart consists of the right atrium and the right ventricle. And then the left side consists of the left atrium and the left ventricle. One thing that you guys should be aware of is that it doesn't really happen in that way. It doesn't happen in this compartmentalized way. The right side and left side actually work simultaneously, meaning that both the right and the left atrium, they contract at the same time, pushing the blood into the right and left ventricles. One thing to be aware of is that when the atria contract, the ventricles are actually relaxed. So they always do the opposite thing. So atria contract, the ventricles are relaxed, ready to receive this blood. And then as soon as the ventricles are filled up with this blood, they contract, pushing the blood into the aorta or the pulmonary artery. So those, the upper part of the heart contracts first, and then it gets delayed by 100 milliseconds after which the lower part of the heart, which consists of the ventricles, contracts. So I added a video for you guys to see exactly how this happens. One thing that I want you to notice about this is how this is the right atrium. There are too many drawings in here. This is the right ventricle, and then this is the left atrium, and this is the left ventricle. Notice how the two atria are contracting before the ventricles. And the way, like, how does this happen? It's a very complicated process, and it requires its own system. So when we look at the muscles and the bones and the joints, we know that they have their own nervous tissue. And when we look at the heart, it's much more complicated, that it requires its actual own electrical system. And one thing that's very interesting about this is that this electrical system is very important in that it can actually work independently of any external stimuli. Like, what does that mean? So let's say that somehow someone goes into a coma and they're brain dead. What keeps them alive? And it's this electrical system that's actually working independently, as in it does not need the stimulus coming from the brain to allow it to act. So what is this electrical system? One thing that you guys should know or should be aware of is the anatomy of this electrical system. One of the main points when it comes to this electrical system is the sinoatrial node. So this sinoatrial node is the headquarters of this electrical system. And the reason why it's called node is because it's a bundle of nerve tissue. So whenever you see a bundle of nerve tissue, we're going to call it node. And the reason why it's called atrium is because of its location. Can anyone tell me what this location is exactly? Does anyone know what this is?
Right atrium.
Exactly. And what is this part?
So between the right atrium and the superior vena cava?
Exactly. So that's why the sinoatrial node is located between the superior vena cava and the right atrium. And you guys should remember this. Like, why is it called atrium? Because it's located in the right atrium. Now the next question is, why is it called sinoatrial node? Does anyone know? Okay, so this is something like for your own information. It's not going to come in an exam or anything like that. But the reason why it's called sino is because of its anatomical location, and the area that it's in is called the sinus venerum. This is just an FYI. You guys don't need to know. So that's why it's called the sinoatrial node. So because it's in the right atrium, and because it's in the sinus venerum. So this sinoatrial node is the pacemaker of the heart. When it starts firing impulses at a faster rate, it causes a fast heart rate. And when it fires electrical impulses at a slower rate, we call it a slow heart rate. So fast heart rate in Greek or Latin is called tachycardia. So tachy basically means fast, and cardia is for the heart. So fast heart. So a fast heart rate is also known as tachycardia. And when the origin of this fast heart rate is the sinoatrial node, we call it a sinus tachycardia. What happens if the sinoatrial node fires at a slower rate? We're going to call this bradycardia. Brady stands for slow and cardia for the heart. So it's a slow heart rate. And when the origin of this decreased rate of electrical impulses is the sinoatrial node, we call it sinus bradycardia. So those are the three main terms that you guys should be aware of now: the sinoatrial node, sinus bradycardia, and sinus tachycardia. So after it fires those impulses, they go to the next step, which is the AV node. Now, the AV node is important in two things that you guys should be aware of. First thing is what I explained a few seconds ago, and that is that the atria should contract before the ventricles. you guys might be wondering, why do we need to have the atria contracting before the ventricles? Why can't they just all contract at the same time? And the answer to this is that when the atria contract, we need the ventricles to be relaxed to receive this blood. If they're all contracting, if all the four chambers are contracting at the same time, then the blood has nowhere to go but outside into the pulmonary veins, into the superior vena cava, etc. So I hope this makes sense to you guys. So this AV node is a station that slows down this electrical impulse by 100 milliseconds to make sure that those atria contract before the ventricles. And this is very important when it comes to the arrhythmias that we're going to talk about in a few seconds. Next step is that those electrical impulses, before moving on to the next step, why is it called atrioventricular node? If you look at the location of this AV node, it's right between the atria, which is this one, and there are too many drawings. It's this one, and this is the right atrium. Okay, so this is the left atrium, and this is the right atrium, and then we have the two ventricles here. So this AV node is right at the border between the atria and the ventricles. Does anyone know where is its anatomical location? Okay, so there's this wall that separates the two atria, and this wall is called the interatrial septum. Septum, which basically means wall, and interatrial means that it's between the two atria. And that's where you will find the AV node. The next step in this electrical system is the His bundle, which is separated into two parts. We've got the right bundle branch and the left bundle branch. So this is the right bundle branch, and we have the left bundle branch. And then they end up as the Purkinje fibers, which go right back up and they integrate themselves into the myocardium to make sure that those electrical impulses reach all the myocytes. Like, we're done with that part. The second thing that we're going to revise is the coronary arteries. So the heart is just like any other muscle. It needs its own blood supply, it needs its own oxygen, and it needs its own nutrients. And that's why the coronary arteries are the most important, basically, blood supply in the body, because it is what makes us survive. The coronary arteries, where do they come from? Where do they originate from?
From the coronaries, the aorta.
Exactly. So what is this? That's the aorta. Exactly. Like, let's just recap on the anatomy. This is the right atrium. Here we have the right ventricle, and we have here the left ventricle. This is the left atrium. So when blood comes from the left atrium into the left ventricle, the left ventricle then contracts, pushing the blood into the aorta. Now, when the blood reaches the aorta, it leaks through two openings. And in Latin or Greek, they call openings as sinuses. So the aortic sinuses there are two aortic sinuses from which the coronary arteries originate from. So just like we have two sides of the heart, left and right, we have two main coronary arteries, right and left coronary arteries. Let's start off with the left coronary artery. So the left coronary artery originates from the left aortic sinus, and then it gives off two branches. One branch is this one. This branch that is originating from the left coronary artery, so that's why we call it left. And because it's on the anterior side, we add the name anterior. And because its direction is moving downwards, we call it descending. It's a left anterior descending artery. Another name for that is the interventricular artery, anterior interventricular artery. And why is it called like that? Because it's found between the two ventricles. The next branch of the left coronary artery is this one. So this is the second artery. Now this artery circles back towards the posterior side, and that's why it's called the left circumflex artery. and then it gives off branches in the posterior side. Now let's go back to the right coronary artery. The right coronary artery originates from the right aortic sinus, and then it continues to give branches to the AV node and the SA node, and then it travels towards the back of the heart, right here, and gives off this very important branch. And that would be called the posterior descending artery. Now, some of you guys might question, why is it not called the right posterior descending artery, just like the left anterior descending artery starts with the left? And the reason why that is because they found that there's 80% of the population has this posterior descending artery originating from the right coronary artery, and only 15 to 20% have this artery originating from the left circumflex, and that's why it's only called the posterior descending artery. But next thing is the territorial arterial supply. You guys might be questioning, why am I even explaining this to you in a physiology lecture? The reason why that is one of the main and most important uses of an ECG is that it shows you exactly what artery is blocked and what side of the heart is it affecting. If one of those arteries is blocked, you can no longer have this blood supply reach the muscle, and when the muscle can no longer get this oxygen or ATP or energy, it dies. And this is a heart attack, or in other words, a myocardial infarction. So that's why I'm explaining the arteries again to you guys. It's just a quick revision, and I hope that this is helpful. So let's talk about the territorial arterial supply of the left coronary artery first. So one of the main branches is the left anterior descending artery, and it supplies mainly the interventricular septum and the left ventricle. Now, when we talk about the left circumflex artery, it gives blood supply to the left atrium and the left ventricle. And then the right coronary artery, because it's similar in circling back to the posterior side when you compare it to the left circumflex artery, it also supplies the right side of the heart, and that is the right atria and the right ventricle. And then lastly, the posterior descending artery, or the posterior interventricular artery, it gives supply to the interventricular septum, posterior side of it. So talking about electrodes, we were just talking about this in the break. One thing that you guys should be aware of is the difference between an electrode and a lead. And for electrodes, basically when a patient comes to the ER and they have chest pain, first thing that they're going to do is plug in an ECG. What does an ECG look like? It's basically a screen or a small TV screen on wheels that they could move from patient to patient. And attached to this screen is those wires. And those wires get attached to those pads. They attach those pads onto the chest of the patient directly so that we can have skin-to-skin contact. And those electrodes, they can measure this electrical activity just through skin. You don't need to insert any needles, no invasive procedures required. And that's the one of the greatest advantages of using an ECG. Those colored large electrodes are put on the limbs. So we have 4 of those, 2 on the arms and 2 on the legs. The pads or the electrodes, we have 6 of them for the chest. But just remember, we have basically 4 main electrodes for the limbs and 6 pads for the chest. So we have how many electrodes in total? That will be 10. 10 electrodes will give us 12 leads, okay? Now, for the ECG, there are many types of ECGs. The most commonly used one is known as the 12-lead ECG. And if they're going to get any question on the exam, it's going to be about 12-lead ECG. It's never going to be about any other type. Then if we, to my knowledge, a 24-lead ECG, and there's probably even more. Now, we have 2 types of leads. And remember that this is different from electrodes. We have the limb leads and we have the chest leads. Chest leads are also known as precordial leads, but it's the same thing. For the limb leads, we have 6 main leads that include lead 1, lead 2, lead 3, and AVL, which basically means augmented voltage left, AVR, which stands for augmented voltage right, and AVF, which stands for augmented voltage foot. Chest leads are from V1 to V6. Finally, the ECG paper. So we've attached the electrodes to the patient. The screen is detecting those waveforms and putting them into leads. What's the next thing? This screen actually has a printer with it, and this printer is going to print out this ECG paper. And this is what it's going to look like. If you guys remember or go back to your school, you used to have this math squared notebook that you used to draw graphs on. And this is basically the exact same thing. That's we can divide it into large squares and small squares. So there are bold lines and then there are light colored lines. The bold lines demarcate the large square. So this is a large square. And then if we take one of those small squares, this is a small square. And yes, you should know that there are 2 types of squares on an ECG paper, a large square and a small square. And I've delineated both of them here for you. So that's a large square. And each large square contains 1, 2, 3, 4, 5 small squares. And that's 1 small square, okay? So like every graph, it has an x-axis and the y-axis. So before we move on to the axis, let's look at the measurement of how many millimeters is each square. A large square, if you take a ruler and measure it, is actually 5 millimeters in height and 5 millimeters in width. The y-axis of this large square is for voltage. So each large square, its y-axis is going to be 0.5 millivolts or half a millivolt, okay? And the x-axis is going to be your duration. So each large square is going to be 0.20 seconds. And if you guys memorize this, it's going to help you a lot in the future slides. Again, the x-axis is for duration and the y-axis is for voltage. Okay, let's say that we take one of those small squares and we put it on the side. So that's 1 small square. And how many millimeters do you guys think this small square would be? And we said here that there are 5 small squares. Who can do the math? If the large square was 5 millimeters in height and width, how much would a small square be? So that's like a math question. Can anyone help?
0.04.
Yeah, not in duration or voltage. I'm talking about the meters or millimeters. How many millimeters would that be? If this one was 5 millimeters in height or 5 millimeters in width, and we take one of those 5 small squares and we put on the side, how many millimeters would it be?
1 millimeter.
Exactly. If I can just divide 5 divided by how many squares, that's going to be 5 small squares, and that would be 1 millimeter. 1 millimeter in height and 1 millimeter in width. How much do you guys think would be the voltage of 1 small square? You're going to do the same thing. Who can help me? Again, y-axis is for voltage, and x-axis is for duration. Now we're talking about the voltage. If 1 large square is 0.5 millivolts, and we take one of the 5 small squares in this large square, and we want to see how much voltage is in that small square, how much is it going to be?
0.1 millivolt.
Exactly. What did you do? How did you find out?
So
You
if 5 small boxes, 0.5, only one will be 0.1.
Exactly, you just divide by 5 and you're gonna get 0.1. طيب يلا, last one. Duration, how much do you think is in the duration of a small square? You're gonna do the same thing.
So 0.2 divided by 5 will give 0.04.
Exactly, and that is going to be 0.04 seconds. Just know that 0.20 seconds is equal to 200 milliseconds, okay? And 0.04 seconds is going to be equal to 4 milliseconds. Is it? 200 divided by 5, that's going to be... Okay, now I'm confused. Anyways, forget about this. Just remember that in height is 0.1 millivolts, so in width it's 0.04 seconds. And that's going to help you guys measure the duration of the voltage of the waves that Rawad told you about. Last part of this basics of ECG. You guys, I'm sure, are all masters of this, so it would be very nice if you guys could help me figure this out. But what do we call this line? Does it have positive, negative deflection, or is it isoelectric? This first line. Exactly. Like what they did in naming those waves is that they took a group of a bunch of letters from the ABCDs and they took the PQRST for some reason. So they just named those waves PQRST, and that's it. And that would make it much easier for you guys. So you guys have probably already seen this. Best, what is this wave called? The yellow one.
P wave.
Exactly. Like, what does it represent? A P wave would represent... Okay, so the first, if we go back to the video that I showed you of the heart contracting, the first thing that was happening is the atria contracting. So before the muscle contracts, we know that an electrical impulse should pass through it to trigger this contraction. And the electrical impulse, in other words, is known as depolarization. So what happens before contraction? That would be depolarization. So the first thing that's going to happen is atrial depolarization, and that is demarcated by the P wave. And this is very, very, very important for your exam, and you guys should memorize this, okay? Now the next wave, what comes after P? That will be your Q wave. And what comes after the Q wave? That will be your R wave. And what comes after the R wave? The S wave. We're just literally saying alphabets at this point. The QRS waves are put together as a complex. When we have more than one wave and we want to group them together, we call it as a complex. And that is why it's called the QRS complex. What does this QRS complex represent when it comes to the heart physiology?
Ventricular depolarization.
Excellent. Yes, exactly. So it is ventricular depolarization. Next wave, before we move on to the next wave, there's this very important segment. And this segment is connecting the P wave to the QRS complex. It's called the PR interval. Does anyone know what this PR interval is representing exactly? Like, why is there no electrical impulse between atrial depolarization and ventricular depolarization? What's the what's causing this break with no electrical activity? What's slowing it down? Exactly. So that would be your AV node delay. So the PR interval is the AV node delay. Now the next wave is going to be your T wave. Does anyone know what the T wave represents? Okay, my bad. Does anyone know what the T wave represents?
Ventricular repolarization.
Yes, and what does ventricular repolarization mean when it comes to the muscle? Is it contracting or relaxing?
Relaxing.
Exactly. Ventricular depolarization is contraction, and repolarization is relaxation. You guys might be wondering, why is there atrial depolarization but no atrial repolarization? And that's because it's hidden within the QRS complex. You cannot see it, but it's hidden within the QRS complex. Last thing that we're going to talk about is this area, and that is the ST segment. So I mentioned previously, you need to have depolarization first, followed by contraction directly. I mean, there's no delay, but it's like it happens right after. So this ST segment is ventricular contraction. Are you guys good with this before I move on?
Yes, clear.
Okay. طيب, checkpoint. Does anyone have any questions? Okay, I think we could move on. But who could solve this question for me? Which of the following waves represent ventricular repolarization? Is it P wave, QRS complex, T wave, or U wave?
T wave.
T wave.
Exactly. That's right. What is P wave for?
Atrial depolarization.
Yeah, that would be atrial depolarization. And what is the QRS complex for?
Ventricular depolarization.
Exactly. U wave is something that we're going to talk about. They just wanted to continue the alphabet, so P, Q, R, S, T, U. I'll tell you guys about it later on. But which of the following waves represents atrial depolarization? We just said it. Is it P?
A. P wave.
Exactly. Like, which of the following waves represent ventricular depolarization? Is it P wave?
QRS complex.
Exactly. I know I'm repeating this a lot, but it's going to help you remember this for future purposes. Like, last question. Which of the following intervals represent AV nodal delay?
PR interval.
Exactly. SC segment is for ventricular contraction. QRS wave is for ventricular depolarization. And QT interval is both ventricular depolarization, contraction, and relaxation. Okay? When we put everything together, this is what we come up with. So this is what a 12-lead ECG looks like. I know it could be overwhelming, but we're going to break it down together. So we can divide it into 3 parts. We've got the lead 1, lead 2, lead 3. And then we've got the augmented voltage right, augmented voltage left, and augmented voltage foot. So those are the limb leads. And then here on this side, on the right side, we've got V1, 2, 3, 4, 5, and 6. Those are your chest or precordial leads. And this part of the ECG is called a rhythm strip. And they specifically took lead 2 because they found out that lead 2 is a combination of lead 1 and lead 3, and also it's on the same direction of your mean electrical impulse. Okay, mean electrical direction. Like, now the leads. So we said that the ECG is going to help us figure out which artery is blocked and which part of the heart is affected. But if we take the inferior part of the heart, which leads are going to be affected? That will be your leads 2, 3, AVF. Don't overwhelm yourselves with memorizing this. I'll show you a better graph that would help you remember this. And then this inferior part is supplied by the right coronary artery. But if they give you a question telling you that a patient comes in with chest pain, on the ECG it shows that there is changes in LEDs 2, 3, and AVF. You know that this is the inferior part of the heart that's affected, and the artery that supplies this inferior part of the heart is your right coronary artery. Now, the next part of the heart that we're going to cover is your lateral or anterolateral part of the heart. And this anterolateral part of the heart is covered with the LEDs 1, AVL, V5, and V6. So that will be your lateral and left ventricle. So LEDs 1, AVL, V5, and V6. I know that this is going to sound very overwhelming, but just trust me and go with the process with me. I'll show you a graph that would help you better remember this. So this side of the heart is supplied by the left circumflex artery. Next side of the heart is this septal, the interventricular septum of the heart, or the anterior side of the heart. And that is shown by LEDs V3 and V4. And the artery that's occluded is the left anterior descending artery. And lastly, the actual septum, that will be covered up with LEDs V1 and V2. And the same artery that supplies the interior side of the heart, which is the left anterior descending artery, is going to give blood supply to this interventricular septum. Just to recap, inferior is LEDs 2, 3, and AVF, and that is supplied by the right coronary artery. The lateral side of the heart is going to be LEDs 1, AVL, V5, and V6, and that is supplied by the left circumflex. And the anterior side of the heart is covered with LEDs V3 and V4, and that is supplied by the left anterior descending artery. And the septal part of the heart is covered with LEDs V1 and V2, which is by the artery that is the left anterior descending artery. So you guys get the point now that different leads show us different views of the heart. So if one of those leads is affected, or a group of these leads are affected, then you know that there's a specific part of the heart that could be in danger or injured. So this is the graph that I was telling you guys about. If you guys could draw a 12-lead ECG and put the numbers 1, 2, 3, and then AVR, AVL, and AVF, and then the chest leads V1 to V6, you will be able to better remember this sides of the heart. But if this inferior part of the graph is affected, you know it's the inferior part of the heart that's affected. And what does this inferior part of the graph consist of? It's LEDs 2, 3, and AVF. If LEDs 1, AVL, V5, and V6 are affected, and we see like abnormal changes in those leads, you know that this is the lateral side of the heart. That probably contains dead myocytes or injured myocytes. And then the anterior and septal consists of V1, V2, V3, V4. Okay. So before moving on to reading an ECG, do you guys have any questions? Or you want me to repeat something?
So in this ECG, there's abnormal inferior, right? Abnormal inferior ECG.
Yeah, that's right. There's ST segment elevation. If you guys, this part is elevated from the normal line. It's elevated. If you guys look at حتى LEDs 1, AVL, V5, and V6, the ST segment is actually depressed. We're going to talk about this. I'll draw you guys the PQRST waves so you can better be able to demarcate which wave is what. This, you're definitely right. So if it's the inferior part of the heart that's affected, which artery do you think is occluded?
Left coronary artery?
Not really, no. It's the right coronary artery. ليش? Why? The heart is actually positioned in such a way that the right ventricle is lying on the diaphragm, making this right ventricle the inferior part of the heart. So what supplies the right ventricle? Is it the left coronary or the right coronary?
Right
What's the
coronary.
point? Exactly. Why? Because it's on the right side. We're talking about the right ventricle. So what gives blood supply to this right ventricle? That would be the artery that's on the right side because it's closer to it. So that would be your right coronary artery. The inferior side is right coronary artery. It's okay. You guys can take your time and memorize this. But if you have any other questions, just let me know. طيب, how do you read an ECG? There's a bunch of steps that you guys should take to be able to read an ECG. هم 10 steps. Starting off with the heart rate. How can you calculate the heart rate in an ECG paper? You guys know that the normal heart rate is between 60 to 100 beats per minute. And if anything is more than 100 beats per minute, that will be your fast heart rate, which is also known as tachycardia. And if it's anything that's less than 60, that will be a slow heart rate, and that is known as a bradycardia. So the way that you do that, and I stress on that this is the first step that you take in reading an ECG, and that is great. And it's very important for you guys to do it in a systematic way, so you do not miss any details. No, this ECG paper is very detailed, but that would help you read it better. So the way that you do that is you take the rhythm strip. If we go back, just a second. If we go back to this paper, this part of the heart, this part of the ECG is called the rhythm strip, and this is what you use to calculate the rate. You do not use this part of the ECG at all. Why? Because this one gives you a recording that lasts for 10 seconds. Tamam? So let's go back to the rate. So the rate, you can do it in two ways. We have the box method and the R waves method. I want to start with the R waves method because this method, you can use it in any time, no matter what the abnormality in the heart is. For the R waves method, what you do is that you calculate the number of odd waves and you multiply it by 6. And another way that Rawad has showed you was basically calculating the number of large squares, and then you calculate how many seconds, and then you divide it by 6. You can do that, or you can just multiply the number of odd waves by 6. So before we do that, I want to just show you where the waves are exactly. So we're gonna ignore this. Okay, we'll start here. This is the P wave, and it's followed by a Q wave, and this Q wave is followed by an R wave, and then S, which is not very obvious here, followed by the T wave. And then we move on to the second heartbeat. The P wave, followed by the Q wave, and then the R wave, and then the S wave, which is not present here, and then the T wave. Okay, and moving on. So can any of you help me find out the rate of this ECG using the R waves method?
$66.
Okay, how many R waves do we have?
11.
Let me count them. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12. I know that you skipped this because I said ignore this, but the reason why I said ignore this is to help you see a full heartbeat. Thus, you should count this one, the first one as well. So you have 12 R waves, and if we multiply this by 6, you get this heart rate, 72. So that's, what is this considered? Is it normal? Is it fast? Or is it slow?
It's normal.
Yes. Type. Let's do the box method. One thing that you guys should be aware of, that you can only use this method if the rhythm is normal. Yani, if someone has an irregular rhythm, you cannot use the box method because there will be differences in the number of boxes between the R waves. Let me tell you more about this. So the way you do this is you take 300 and you divide it by the number of large squares between two R waves. So you take any two R waves and you count the number of large squares. So I'll take this odd wave or this odd wave. Let's count them. This is one large box, second large box, third large box, and fourth large box. So those are 4 large boxes. And if we divide 300 by 4, how much is that going to be? 300 divided by 4 is 75. So that's very close to the Arrhythmias method that we just did. Again, I want to emphasize if this was not a normal rhythm, you cannot use this box method. Next step. So we're done with rate. Does anyone have any questions about that? Okay. طيب, can anyone determine the rate of this ECG? And it would be really good if you guys could walk me through it as you do it, so everyone could benefit from this. Like, what are you going to use? Is it the upper part of this ECG or the lower part to count to determine the rate? We're going to use the lower part. Yes, that's the lower part. Why? Because we said that lead 2 combines lead 1 and lead 3. But it gives us a very clear picture of all the waves that we just talked about, the P, Q, R, and S, and T. And the second reason is because it measures the waves for a duration of 10 seconds. Like, can you determine the rate of this? You can use any methods, either the box method or the R-waves method. Take your time.
So it's almost 120.
Okay, how many R-waves were there?
Because I use the box method, and it's approximately 2 big boxes between each R-wave.
Okay, so 300 divided by 2 is 150.
Yes.
Tamam. Is this fast, normal, or slow?
Tachycardia, it's fast.
Like, when this, you're absolutely right. This is tachycardia. 150 beats per minute is very fast. If this tachycardia is caused by the sinoatrial node firing at a very fast rate, what do you call this?
Sinus tachycardia.
Exactly. So this is called sinus tachycardia. Now, the next one, since you got this, is going to be much easier. Can anyone help me figure out the rate in this ECG? Are you going to use, first question, are you going to use this upper part or the lower part? That will be your lower part. This is called the rhythm strip. Okay. So this is the rhythm strip. You're going to use this to measure the rate. I'm using the chat or not. Oh, you are. Okay, my bad. Like, so for this ECG, the first thing that we're going to do is that we're going to look at the rhythm strip to determine the rate. And we're going to talk about why is it called rhythm strip in a few seconds. Thus, the way you're going to do that is 2 ways. We said there is the box method, and then there's the R-waves method. So if we start off with the odd-waves method, you can count the number of R-waves. So we have 1, 2, 3, 4, 5, 6, and 7. And then you multiply this by 6. 7 by 6 is going to be something around 40. Okay. 42. So the heart rate is 42. Is this considered fast or slow?
Slow.
Yes. So what do we call this in Latin or Greek? Oh, medical terms. What do we call this?
Bradycardia.
Yes. And if this comes from the sinoatrial node, we call it the sinus bradycardia. So this is sinus bradycardia. You can use the R waves method, or you can use the box method, which is basically counting the number of large boxes. So if we count them, we can count this as 1, 2, 3, 4, 5, 6, and 7. And then you divide 300 by 7. And that would be 42 again. So the heart rate is 42. This is sinus bradycardia. Next step is the rhythm. So the rhythm, you determine the rhythm by using the rhythm strip. And that's what it mainly is for. And I've shown you guys what the rhythm strip looks like and where it is located in an ECG paper. And the way that you do that is you look at the R waves, and then you count the number of large boxes in between every 2 R waves. So if we take this R wave and this R wave, then we count the number of large boxes. We have 1, 2, 3, and 4. So the first RR interval consists of 4 large boxes. And then you have to compare this interval with the rest of this strip. It has to be the same number of large boxes in between every 2 R waves. Let's count this again. This is an R wave and this is another R wave. For 1, 2, 3, and 4. It's consistent. Let's try it again on a random odd interval. This is an R wave. This is an R wave. Let's count the number of large boxes. 1, 2, 3, and 4. So it's consistent. At the start, you guys will need to count the number of large boxes, but with time, you can literally find out the rhythm just by giving it a look without even needing to count the number of large boxes. So if the number of large boxes is consistent in every RR interval in this rhythm strip, we're going to call it a regular rhythm. If, for example, we have 4 large boxes and then suddenly 5 and then suddenly 6 and then low, and then like 3 or something like that, then we're going to call this an irregular rhythm. The best place to see the rhythm is going to be in your lead 2, which is the rhythm strip, basically. So let's do a small exercise. Can anyone figure out if this is a regular or an irregular rhythm? Or do you guys want me to demarcate the... Okay, let's do it this way. Are we going to use the upper part or the lower part of this ECG? We're going to use this rhythm strip. Yeah. So the rhythm strip is going to help us find out the rhythm, basically. So what we're going to do, for example, is start here. This is a P wave, Q wave, odd wave, and then the S is not here, and then a T wave, and then there's no P wave for some reason. There's no Q wave for some reason. We go up, and then R, and then a very deep S with an inverted T, and then a P wave, and then a Q wave, and that's it. So this is an R wave, this is an R wave, this is an R wave, this is an R wave. And if we count the number of large boxes between every R waves, we're going to get, for example, this one, 1, 2, 3 large boxes. And then between those 2 R waves is 2 large boxes. And then between those 2 R waves, we have 3 large boxes. So is this regular or irregular? Exactly, this is an irregular rhythm. Why did we call it as regularly irregular? If you continue with this, you find out, so we said here it starts with 3 large boxes and then 2 large boxes, and then again 3 large boxes, and then 3, and then 2 large boxes, and this is another R wave. That's going to be 3 large boxes. So you notice that there is a sequence in here. Those are 3 large boxes in between those 2 R waves. So you notice that there's a sequence in here, and 3, 2, 3, 3, 2, 3, and like it repeats itself. That's why we say it's regularly irregular, because it comes at a sequence. However, if it's like this and there's no specific sequence, it's just random R waves in a random number of large boxes, then we call it another name. And we'll tell you about that in a few seconds. But then let's demarcate the R waves in here. So this is an R wave. So this is an abnormal ECG, and that's why you do not see all the waves in it. This is an S wave, and then a T, and then there's no P or a Q, but then there's suddenly an R, and then an S wave, and then a T wave. The point is not looking at the P, Q, S, or T waves. We're focusing on the R waves in here when it comes to the rhythm. And also look at LED 2, not V5, my bad. So we'll look at the R waves. So this is an R wave. This is another R wave. And then we count the number of large boxes. So 1, 2, and 3. Those are 3 large boxes. And then we look for the next R wave. And this is the next R wave. And then this is the 4th R wave. And then we have the 5th R wave, and the 6th R wave, 7th, and the 8th, etc. But then you count the number of large boxes here. There's 1, 2, 3, 4, 5, 6. And then here there's 3. And then again, 3 large boxes. And then again, 3. So there's no specific sequence, and that is why we call this an irregularly irregular rhythm. And this is basically what an atrial fibrillation is, okay? If you guys see those keywords, irregularly irregular, you just know that this is atrial fibrillation. This is a pathology, okay? Next thing is the QRS complex. So if we go back and demarcate it, one thing that you guys could do, let's take LED 2 for example. We're right here. So this is the R wave, sorry, Q, R, and then S wave. And if we count the number of small squares, that's going to be 1, 2, and 3 small squares. 3 small squares is how many seconds? If one small square has 0.04 seconds, and we want to know how many seconds is in 3 small squares. You're going to multiply this by 3, and that is 0.12 seconds. So the QRS complex that you guys have just seen is a normal QRS complex with a normal width. If it's more than 0.12 seconds, we call this a wide QRS complex, and if it's less than 0.12 seconds, we're going to call this as a narrow QRS complex, or you can just memorize it using the number of small squares. Sinus P wave. The next step, we finished the rate, the rhythm, and then we talked about the QRS complex. And the 4th step is the sinus P waves. You check all the leads in the ECG, and then you see if all the P waves are facing upwards. So if you go back to this ECG, let's look at LED 1. So this is a P wave, because this is a T wave. Why is this one a T wave? Because it's following a QRS complex, okay? So this is a P wave, and then you have your QRS complex, and then the T wave, and then a P wave. We're focusing on the P wave. Are all the P waves facing upwards except in AVR? LED 1 is facing upwards. We're good to go. This P wave is facing upwards in LED 2, and this is another P wave. It's facing upwards. We're good. And then we look at LED 3. This is another P wave followed by Q, R, S, and then a small t. Is the P wave facing upwards? Yes. And so on. You do the same thing on the rest of the leads, except for AVR. It has to be facing downwards. So this is a P wave, and then a Q. So it's the exact opposite of what a normal waveform of an ECG looks like, and that's normal, okay? So you always check AVR if it's the opposite. Going back to sinus P waves. So after finishing this P wave is a PR interval. PR interval, the normal one, is 5 small squares, okay? Anything more than that is going to be a prolonged PR interval, which basically means that the AV node is taking a longer time in delaying this electrical impulse. It's slowing down the electrical impulse much more than it needs to. So that's when a PR interval is prolonged. However, if it's conducting this electrical impulse at a faster rate, then we call this a short PR interval, okay? Next thing is going to be your ST segment. Ignore this, just know that P wave followed by a Q, R, and then an S wave, and then a T wave. Now this small waveform that I've attached here is abnormal. And why is that? Because the ST segment, which connects the S wave to the T wave, is actually elevated. Why is it elevated? Because this is the normal line. It should be right here. It shouldn't be this cell. If it's more than one small square elevated upwards, then this is considered an ST elevation. This one thing that you guys should focus on is that it has to be in a group of leads. A group of leads that cover a certain position of the heart. So we talked about the inferior part of the heart. We talked about the lateral part of the heart. So if it's just, for example, lead 1, and you look at the rest of the ECG and there's no ST segment elevation, then this is considered normal, okay? You should not consider this as a myocardial infarction unless it happens in a group of leads. If it's in one lead, then this is considered normal, okay? ST segment depression is something you shouldn't worry about. Just focus on ST segment elevation. ST segment elevation is a sign of a heart attack or a myocardial infarction. T wave, as we know, is the ventricular repolarization, and that's all what you should know about this. And then we have the QT interval. So the normal QT interval is between 390 to 460 milliseconds, okay? Anything more than 460 milliseconds is considered a long QT interval, and there's a syndrome that is known as the long QT syndrome that you guys took in your lecture. So this is what a long QT syndrome is. If we look at this strip, why am I looking at this one? Because it contains lead 2, and we said lead 2 is the best lead that we can look at. It basically delineates all the waves in a better way when you compare it to other leads. So this is a P wave, and then we've got the QRS, and then a T wave, and then a P wave. This is the P wave, and then a QRS, and then the T wave is not there for some reason. The P wave. So okay, I made a mistake. So ignore this. I was saying that if this is the P wave, QRS, and then a T wave, if you guys look at the distance between the Q wave to the T wave, it's probably 2.5 large squares. And 2.5 large squares is, if every large square is 0.20 seconds, and we have 2.5 large squares, and we multiply this, that's going to be around, let's say, 0.5, which is equal to 500 milliseconds. And we said anything more than 460 milliseconds is considered a long QT interval. This is what long QT syndrome is, okay? Okay, so the 9th step is the cardiac axis. And there are 3 main ways that you can figure out what the cardiac axis is. And what the cardiac axis is basically the net electrical potential, or the direction of this electrical activity. And the most important thing that you guys should remember about this is that the normal electrical cardiac axis, the main cardiac axis, is between -30 to a +90. Would you guys like to take a break before we move on to this? Because this is kind of a bit like heavy topic to talk about. Do you guys want to break or do you guys want to continue?
Yes, please, let's take a break.
Okay. Would 5 to 10 minutes work?
Yes, thank you.
Okay, no problem. All right, so back to the cardiac axis. The first thing that you guys can do, and that would help you so much in answering the questions, is drawing the cardiac axis yourself. So I'll need you to take out a paper and a pen and draw this with me. So if we have, we're gonna draw a y-axis and then x-axis, okay? We're gonna give this 0 degrees and then positive 90 degrees and then 180 degrees. And on the upper side, we're gonna give it a negative 90 degrees. The upper side is negative and the lower side is positive. So anything between 0 to 180 is positive, and anything between 180 and 0 is negative. Okay? And then you continue on to draw the rest of the lines. So we're going to have a line that's very close to 0. That will be negative 30. And then another line is going to be positive 60. And then another line that is positive 120 degrees. And then the last line, negative 150 degrees. The more you guys draw this, the more you repeat this, the easier it's going to get for you. But we said that the normal cardiac axis is between negative 30 and positive 90. If the cardiac axis, which is the direction of the electrical activity, the mean direction of electrical activity, is lying, like, for example, if it was this one, and it's lying between negative 30 and positive 90, then this is a normal direction of electrical activity, and this is a normal cardiac axis. Let's say that if we go back to the slide, we said that the normal cardiac axis is between negative 30 and positive 90. If it was more towards the right side of the normal QRS axis, that would be the right axis deviation. And the right axis deviation is between positive 90 and 180 degrees. How would you remember this? Again, by drawing this cardiac axis. Again, x-axis, y-axis. We're going to get 0 degrees, 180 degrees. What's between that will be your positive 90 and negative 90 degrees. We said that a normal cardiac axis is between negative 30 to positive 90. So this is normal cardiac axis. And then if we move on towards the right side, anything between positive 90 in this quadrant, anything between positive 90 and 180 is a right axis deviation, which means that the axis deviated towards the right side. What if this axis deviated towards the left side? If it's in this area between negative 30 and negative 90, if it's in this area between negative 30 and negative 90, that will be a left axis deviation. So left axis deviation. which basically means that the axis deviated towards the left side. And then this area, or this quadrant, which is between -90 and 180, is an extreme axis deviation. So it's the extreme opposite of this cardiac axis. So let's go back. Same thing again. Normal QRS axis is between -30 and +90. And then a right axis deviation is between a +90 and 180. And the left axis deviation is between a -30 and a -90. And anything that's other than those, it's not normal and it's not left or right axis deviation, that will be your extreme axis deviation. So we said there are three main ways. We're only going to talk about the quadrant method and the net zero lead method. The quadrant method is fairly an easy way to do it. And the way you can do it is looking at two parts of the ECG paper. The first one is going to be your lead one, and the second part is going to be your AVF. But if we go back to the ECG paper that I showed you a while ago, we're going to look at lead one and AVF. What exactly are we going to look at in lead one and AVF? And that will be in R waves. So this R wave and this R wave. And what are we going to talk about exactly? That would be the direction of this R wave. If they're both pointing upwards, then this is normal. If they're both pointing downwards, or they're both negatively deflected, then this is the extreme opposite direction. And that's why we call it an extreme axis deviation, okay? So both upward is normal, both downward is an extreme axis deviation. If, let's say, if we go back to this cardiac axis, remember that the left axis deviation is on the upper side of this line. So that's how you remember whether the R wave in lead one is up or down. So if it's a left axis deviation, then the R wave in lead one has to be facing upwards. And the one in AVF is going to be the opposite. It's going to be facing downwards. Right axis deviation, if you guys go back to this circle, you're going to find that the right axis deviation is below this line. Okay? So that's how you remember that the R wave is in lead one downward facing, and in AVF it's an upward facing. Let's do a small practice. Let's say we looked at lead one and AVF. This is lead one, and this is AVF. And we found out that both R waves are facing downwards. What do we consider this?
Extreme deviation?
Exactly. So this is an extreme axis deviation. What if they're both facing upwards?
Normal.
Exactly. But if they're facing the opposite side, thus the R wave in lead one is facing upward, and in AVF is facing downward. Remember, what's up? Is it left or right axis deviation? If we go back to the circle, we said we could divide it. Just quickly, this is left axis, and this is right axis deviation. So you look at this line. What's above this line? Left axis. So you know, since this R wave is facing upwards, then it must be left axis deviation. But this one is left axis deviation. What if this R wave is facing downward in both lead one and AVF? So this is below the line. What is this? Is it normal or there's an axis deviation?
Axis deviation.
Which one?
If both negative, it's extreme.
Right. Okay, so what if one is downwards in lead one, and in AVF, it's facing upwards? It's below the
Right
side.
axis deviation.
Exactly. So that's going to be your right axis deviation. This is like a way that you can figure out if the cardiac axis is normal or if there's an axis deviation. When do we have a right axis deviation? That will be if you have a right ventricular hypertrophy. So just remember, right axis deviation is right ventricular hypertrophy. If you have a left axis deviation, that happens in the case of a left ventricular hypertrophy. What is the physiology behind this? If you have more myocytes in the left ventricle, and this happens due to hypertrophy, they're going to require more electrical activity. So that's why the cardiac axis is going to shift towards the left side. And that's why we have a left axis deviation. If you have a right ventricular hypertrophy, you'll have more myocytes in the right ventricle when you compare it to the left ventricle. The more myocytes in the right ventricle is going to pull this electrical activity. It's going to require much more electrical activity. And that is why the cardiac axis is actually tilted or deviated towards the right side in case of the right axis deviation. I hope that's clear for you guys. Do you guys have any questions about the quadrant method before we move on?
Can you repeat how to differentiate between LAD and RAD?
As in, oh, okay. So for the left and right axis deviation, look at this cardiac axis circle, let's call it. We know that this is the normal axis, QRS axis. Okay. Let me do it here. I think that would be better. If we draw this, okay, let's call this line. Okay. We know that the right axis deviation is right here, right? If you have like, if you're more of a visual person, you just know that the right axis deviation is on this side and left axis deviation is on the upper right side. Okay, so anything if it's above the line, that will be a left axis deviation, and if it's below the line, that will be right axis deviation. Why am I saying above and below the line? No, when you look at the cardiac axis, you look at two parts: lead 1 and AVF. Okay. If lead 1 has an R wave facing upward and then AVF R wave facing downwards. Since you focus on the lead 1, if the R wave is facing upwards, then you go back to the circle and see which one is above the line. Is it the left axis deviation or the right axis deviation? I'm talking about this line. Which is above this line? Is it the left axis or the right axis?
Left axis.
Yes. So it's above, as in like it's upwards. So you know that the R wave has to be facing upwards. In both left axis and right axis deviation, the R waves in lead 1 and AVF are facing the opposite sides. How do you know which one is which? Is by this trick. And that is basically learning how to draw this circle. You just remember that the left axis deviation is above the line, meaning that the first R wave, which is in lead 1, is facing upwards. And if the lead 1 R wave is facing downwards, then the axis deviation is probably below the line, below this line, okay? So that's going to be a right axis deviation. Obviously, this is going to be like towards the opposite side. That's how we know that this is a right axis deviation. I hope this answered your question. I could repeat it if you're still finding difficulty with it.
So if it's left or right, only on lead 1, right?
Yeah, you have to look at both lead 1 and AVF.
Yeah.
But for this trick to work, you just look at lead 1.
Okay, thank you. Yeah, thank you so much.
No problem. So the next method is a bit more difficult, we could say, but we can do it, inshallah, because you guys have learned and you probably know much more about this positive and negative deflection than I do. So this wave that's shown in this graph is positive, and that is because the R wave is longer than the S wave. It's more positive and it's facing upward. This graph, on the other hand, the QRS complex is more negative, it's more pulled down. Thus, if both the R wave and the S wave are equal in distance, we call this an equiphasic wave, let's say. Look at this. If the QRS complex is positive in any given lead, the axis points in roughly the same direction as the state. For example, if lead 1, if you look at the QRS complex and it's positive, as in it's facing upward mainly, then the cardiac axis is going to be more towards lead 1, which is here. Okay, so it's going to be facing towards this side. And this is another thing that you should add to the drawing when you practice on it. The leads is very important and it's going to help you answer the questions on the exam day. Next point is saying if the QRS is negative in any given lead, the axis points in roughly the opposite direction. So just remember, positive is same direction of cardiac axis, and negative is the opposite direction of the cardiac axis. So let's say that lead 2 has a QRS complex that looks like this, and it's facing downwards. Then we said that to what's on the opposite side, that will be your AVR, because like we're looking at the opposite side. But the cardiac axis is going to be facing this side. Okay. If the QRS is isoelectric or equiphasic in any given lead, then the axis is perpendicular to the lead. I'll give you an example for this so you guys could better understand this. Thus, if, let's say, lead, if you're looking at the ECG and you notice that lead AVF has this type of wave, as in the R wave is similar in distance to the S wave, okay? So this is equiphasic. That's the first part that you should understand. This is equiphasic. Now the next thing, how do we figure out the cardiac axis from this? So we said if it's equiphasic, then it's going to be perpendicular. The cardiac axis is going to be perpendicular. We said AVF. We said AVF is equiphasic. So what's perpendicular to AVF? It's lead 1. So the cardiac axis is going to be facing lead 1. Let me give you an example to help better explain this. If we look at this ECG, we divide it into 3 main parts. Focus on lead 1. Is this equiphasic, positive, or negative? As in the QRS complex. Is it equiphasic, positive, or negative?
Negative.
You're right, it's more of negative. But for example, let's say that if it's negative, we said here that the axis should point on the opposite direction to the lead. So we said lead 1 is negative, so this axis should point to the opposite direction. So the axis is going to be 180 degrees, which is abnormal, which is between right axis deviation and extreme axis deviation. Like, let's say that this was equiphasic. If lead 1 had a QRS complex that was equiphasic, and the R wave is similar in distance to the S wave. In this case, we said if it's equiphasic, then the cardiac axis is going to be perpendicular. So we look at lead 1, said it's equiphasic, so we look at the lead that is perpendicular. Perpendicular means that it creates a 90-degree angle with this line. So what's perpendicular to this? If this is 90 degrees, that will be your AVF. So how do we know if it's facing the negative side or the up or the positive side? You look at AVF. Is this positive or negative? It's positive. Yes, it is positive. But this means that the cardiac axis is facing the positive side and not the negative side. I hope this makes sense. If not, we can do more practice problems in this. Do you guys have any questions, or do you want me to repeat any of those?
Can we have another example?
Okay, sure. Fine. Let's say that, for example, lead 2, if this was a different ECG and lead 1 was normal and lead 2 was positive, we said that if the QRS is positive, then the cardiac axis is going to point in the same direction as this lead. We're focusing on lead 2 and it's positive. So two things that you should know about this. Lead 2 and it's positive. You go back to the circle that you drew before the exam on a separate paper, and then you look for lead 2. We said that if it's positive, then it has to be in the same direction, meaning the cardiac axis is somewhere facing the same direction as this lead. Okay, so that was an example for the positive QRS complex. Let's say that it was a negative QRS complex. So let's take AVL, for example. If AVL is facing downwards, for two things you should know about this. AVL, write this down on the side, it's facing downwards, meaning it's negative. So you go back to your rule. If it's negative, then the cardiac axis is in the opposite direction to this lead. We were talking about AVL. And we said it's negative, so it's pointing to the opposite side. So it's going to be more of the right axis deviation. So the cardiac axis is going to lie in the area of the right axis deviation. I know this is complicated, but the more you guys draw this graph, the easier it's going to get. Thus, the main and most basic point about this is to remember that the normal axis deviation is between -30 and 90 degrees. And I think that the quadrant method is much easier than this net zero lead method. We're going to do some practice questions on it later in MCQs, okay? I hope this helped you understand it better.
Yes, thank you.
No problem. Last thing is the U wave. So they continued PQRSTU, and they found out that when people have hypokalemia, which basically means very low levels of potassium in your blood, this wave pops up, and it comes right after the T wave. Look at this. So this is a P wave, and then you have a very small Q wave, and then R, and then this is the S wave, and then you have a T wave. What comes after a T wave? That will be your U wave. So if you see this, that's a sign of hypokalemia. Another nice way that I'm explaining it is that sometimes you see that the T wave is facing downward, which in other words means inversion, but they call it T wave inversion. So if you push it down, if you push the T wave down, another bulb is gonna come out, and that would be your U wave. So this is hypokalemia, okay? So that was reading an ECG. It was like 10 main things. We talked about the rate, we talked about the rhythm, the QRS complex, then you check the sinus P waves if they're present, then you check the PR interval if it's normal or prolonged, then you look at the ST segment morphology in case there was an MI or a myocardial infarction, and then we talked about the T wave, should be facing upwards, not the opposite side. And then we talked about the QT interval duration and the lung QT syndrome. We talked about the cardiac axis and the U wave. So that was 10 steps to reading an ECG. As I previously said, this is not to help you guys master this, because it's going to take so much time and effort. Let's just get the basics, know how to answer the questions, and inshallah this should help you answer the questions in the exam. So who can help me answer this question? First thing that you should do whenever you read a question, when it comes to either the final exams in med school or your medical license exam like the USMLE, is look at the answers. What are they asking about? Are they asking about the QRS complex? Are they asking about the cardiac axis and so on? If you skim through those options, you see that they're asking about the cardiac axis. But you know directly what exactly you need to do, so you do not get overwhelmed with this ECG paper. But if they're asking about the cardiac axis, how would you do the quadrant method? what are the two leads that you should look at?
One and AVF.
Exactly. And what exactly are we looking at? Is it the P wave, the QRS complex, or the T wave?
R wave.
Exactly. So that will be your R wave. What's the next step? You looked at LED 1 and AVF. So LED 1, the R wave is it facing upwards or downwards?
So R is positive and AVF is negative.
Exactly. So what do you think this is? Look.
Left
would
axis
say-
deviation.
Yes, because it's above the line. So the answer would be your left axis deviation. Next question. Which of the following leads are used to diagnose left ventricular hypertrophy? What is a sign of left ventricular hypertrophy? It was
Left axis deviation.
Exactly. So that was left axis deviation. How do we determine the axis, if it's deviated or not? That is by the cardiac axis. And the cardiac axis is figured out by LEDs. What LEDs exactly? Which of the following options do you guys use?
D.
Exactly. So you figure out the cardiac axis by looking at leads 1 and AVF. Okay. Third question. If your cardiac axis is at positive 120, which of the following is the lead that would have the strongest negative deflection? Now this sounds like a complicated question, but let's do it together. If we go back and draw the circle, we draw the y-axis and the x-axis, and then we put 0 degrees, and then 180 degrees, 90 degrees, that is positive, and then negative 90 degrees. And then the extra details, which is the, negative 30 degrees. And then here we'd have the 60 degrees. Only reason why I remember this is because I drew this again and again and again. And this is the best way for you guys to remember this. And the rest of the details is positive 120 degrees. And then here is what you have as the negative 150 degrees. Okay? Normal cardiac axis is what? Between which of the following degrees?
From -30 to positive 90.
Exactly. So this is your normal axis deviation. I abbreviated it as NAD. And then the left axis deviation is going to be between what and what? It's going to be mainly this quadrant. So that would be left axis deviation is going to be between 0 degrees and negative 90. And then right axis deviation is going to be between, in this quadrant mainly, that's going to be between positive 90 and 180 degrees. And anything between 180 degrees and negative 90 is an extreme axis deviation. How could they get to a question in this? They could, for example, say a patient has a cardiac axis that is, let's say, positive 50. Is this normal or abnormal?
Normal.
Why do you think it's normal?
Because it's full under -30 and +90.
Exactly. And they could get you another question, like if it's, for example, positive 150, and again, you draw this line, the x-axis and the y-axis, and you plug in the numbers, and then you say, oh, look, the cardiac axis is facing this side of the quadrant, which is right axis deviation, and so on, okay? So for this question, for you to solve this, you're going to need to use the net lead method, which is also known as the isoelectric method. So the way you do that is that they're saying that the mean electrical axis is at positive 120 degrees. How do you figure this out? you plug in the leads, which we did not do so far. So at 0, we have lead 1, okay? And then at positive 60, we have lead 2, and then skip 90, and then at positive 120, you have lead 3, and then you have lead AVR negative 150, and lastly, you have AV, okay? So they're saying that this is the cardiac axis. It's facing positive 120, meaning it's lead 3. And they're saying, what is the strongest negative deflection? So what is that supposed to mean? This basically means something that is the complete opposite or perpendicular to it. So what's perpendicular to the positive 120? Is it this one, or this one, or is it this one?
AVL?
120 minus negative 30, that's more than 90 degrees. Perpendicular basically means it has to be 90 degrees. What's at 90 degrees with this line? I think it's more towards this line, which is AVR. Because if you drew a square, this would be more of a, like this, I mean, 90 degrees. So the answer is AVR. It's going to have the strongest negative deflection, which means perpendicular. Okay, so the answer is going to be AVR. Does that make sense?
Yes, it does.
Okay, thank you. Finally, we're just going to do a quick recap of what we learned previously. You guys are going to take over the rest of this presentation because, inshallah, you understood everything that I have tried to explain. Okay? Okay, so what is the first thing that you do when reading an ECG?
Heart rate?
Exactly. So what are you going to use in reading the heart rate?
The lower one, and we
Which
see
is
the R
called the rhythm
waves.
strip. Yes, the rhythm strip. So you're going to count the number of R waves. Oh, do it and tell me what your answer is. If you guys could also help in the chat, that would be very helpful.
So it's almost 2 boxes in between each R wave. So I think
Okay.
150.
Okay, so what is your diagnosis for this patient?
Tachycardia.
What kind of tachycardia?
Sinus tachycardia.
Exactly. Sinus tachycardia, more than 100 beats per minute. Something that's an FYI. And how do you know what's the maximum heart rate that a person can reach? And you can just take 220 and subtract it from your age. Okay. What about this one? So we do not have a rhythm strip for this one for some reason. But without the need for a rhythm strip, what do you guys think the heart rate could be? And let's use a random lead. For example, we said that we use lead 2. How many large squares are there in between those two odd waves?
8 big boxes.
Okay, and if you divide 300 by 8, that's going to be 37.5. Is 37.5 considered normal, slow, or fast?
So it's going to be sinus bradycardia.
Exactly. So this is sinus bradycardia. And we used the box method for this one. Why did we not use the odd waves method for this one? Because we do not have the rhythm strip. And if we don't have the rhythm strip, we cannot count the number of odd waves in a duration of 10 seconds. So in this case, you can opt for the box method, and then you can count the number of large squares in between the odd waves, and then you divide 300 by this number. And the answer for this one is 37.5, and that is sinus bradycardia. So anything less than 60 would be considered the sinus bradycardia. MI is delineated by an ST elevation. We said if the ST segment is elevated by one small square in a group of leads, then we would start thinking of a possible myocardial infarction or heart attack. And this is usually caused by a blockage of the coronary arteries, which causes less blood supply to the myocardium, leading to death of the myocytes. And then you get those changes in the ECG. And that's why the ECG is very helpful in telling us what is going on with the heart. Okay? So this is a question. You can, first of all, again, in solving any questions, look at the answers. What are they trying to make us figure out? So it's all MI. So they want to know which side of the heart is affected by this MI. So you can literally just skip all of this and read the last thing. What is the most likely diagnosis? Let's take a look at the ECG. By this ECG, can anyone tell me where the ST elevations are? So we have the rhythm strip here.
Lead 2 and 3.
Okay. What does this remind you of? 2 and 3, and there was a third lead. If all of them come together, they're going to tell us that there is an infarction. 2, 3, and what lead? It's okay if you don't remember any, because like it's a bit hard to remember.
On the bottom one.
Okay, so if it was the ones that make a corner for this graph, so that would be that's 2, 3, and AVF. Look at if this was a P wave, a Q wave, R, and then you've got the ST segment. Look at how elevated it is. It's one small square above the normal line, which should be this one. And this one, if we draw the normal line, it's one small square elevated. And again, if we draw the normal line, it's one small square elevated in AVF. Oh wait, I went down to rhythm strip. So if we draw the normal line, it's going to be one small square above the line. So if we have ST segment elevations in LEDs 2, 3, and AVF, that would be an inferior myocardial infarction. What if it was in LEDs 1, AVL, V5, and V6? Do you guys remember what that was for? LEDs 1, AVL, V5, and V6. We can go back to the table. And that would help you guys remember this. So if it was LED 1, AVL, V5, and V6, that would be the lateral side of the heart, or you could call it a lateral MI. And this, the artery that's affected is the left circumflex, okay? This is the graph that I was telling you guys about, and it's much easier for you guys to remember what leads should be grouped together and what they stand for. But remember, the corner of this graph is made by LEDs 2, 3, AVF, which is the inferior. So it's the inferior corner, you can remember as the inferior part of the heart is affected. And if it's this random number of leads, like leads 1, AVL, V5, and V6, then this is lateral. And if it's from V1 to V4, you could call it as interior-septal. It's not only anterior, it also includes septal, as we mentioned here. Okay? So let's go back to the ECGs. Okay. So this is another question. First thing that you're going to do is look at the answers, check what they're looking for exactly. So they're asking about arteries. And what is associated with arteries when they're blocked? That would be an MI. So when it comes to MIs, you need to group the leads together when it comes to ST elevations. You can just skip all of this and look at the ECG, okay? So this ECG, where are the changes? And what part of the heart is affected? start checking it systematically from lead 1, 2, 3, and then AVR, AVL, AVF. If you look at lead 1, there's ST elevation. In lead 2, there's no ST elevation. In lead 3, there's actually ST depression, which is not something you guys should really know at this point. But it's not something they should be worried about. They look at AVL, there's ST elevation. And then AVF, there's ST depression. And they look at V1, again, ST depression, V2, ST depression. Now, we said when it comes to the heart's point of view, we want to look at the ST elevation and not the depression. So, and then we look at V4. There are no changes in the ST. V5, there is some ST segment elevation. So we circle V5 and V6. So if it includes LEDs 1, AVL, V5, and V6, which part of the heart?
It's the lateral view.
Exactly, it's a lateral view. That, I think it now makes sense why I told you guys to use that graph instead of just memorizing it as random numbers. This is a lateral MI. So what about this one? Where do you see the ST elevations?
Again, the same. 1, AVL, 5, and 6.
Exactly. So what do you consider this? Oh, by the way, if you look at V2 and V3 command, it's also involved. Look at this. Right?
And
There's
maybe
also
even V4, right?
Yes, V2, V3, and V4. Let me go back from the beginning. So you have ST elevation lead 1, lead 2 is normal, lead 3 is normal. You skip AVR. You look at AVL. You could say that there is some ST elevation. So lead 1 has ST elevation, lead 1 and AVL. AVF is normal. V1 is normal. V2 has some ST segment elevation for you circle it. V3 has ST segment elevation for you circle it. V4 also has some ST segment elevation. V5 also has it for you circle it, and V6. In the ECG before this, we said lead 1, AVL, V5, and V6 is lateral. What if we also have ST elevations in leads V2, V3, and V4? What part of
Maybe the
heart?
septal part.
If V1 was also involved, it would be septal. But this is, since V3 and V4 are, like, does that make sense? I know we said if only one lead from the groups of ECGs that we talked about is affected, then we should not consider that this part of the heart is affected. So I know we said that the septal is V1 and V2, right? Since V1 is normal and only V2 is elevated, we do not think that this is septal. As we look at V3 and V4, which is the anterior part, since there's ST elevation V3 and V4, then we say that this is more anterior. Thus, we also have the lateral part affected. So what kind of MI do you think this should be called? You combine them both together. So you say it's anterolateral MI. Okay? Okay, next one. So lead 1 does not have ST elevation. It's a bit cut off. This is lead 1, this is lead 2, and this is lead 3, and this is the rhythm strip. Okay, so lead 1 does not have ST elevation. Lead 2 has ST elevation. Lead 3 has ST elevation. And then AVR, you ignore it. And then you look at AVR, does not have ST elevation. AVF has ST elevation, so you circle it. V1 does not have ST elevation. V2 has ST elevation. V3 has ST elevation. And V4 also has ST elevation. And V5 and V6. So what kind of MI do you think this person is having? If it involves 2, 3, AVF, V2, V3, V4, V5, and V6.
Anterolateral.
We would only say it's lateral if it involves leads 1, AVL, V5, and V6. You might be confused because V5 and V6 are affected. Why is this not considered lateral? That is because V5 and V6 are the only ones that are affected, and 1 AVL are normal. And we said that we need the full group to be affected or to have ST elevations for you to consider this as a lateral MI. But if it's only V5 and V6, then this is not lateral. Thus, what are the ones that are affected? We have leads 2, 3, AVF, V2, V3, V4, V5, and V6. What groups do you see here? First group, what is this? Is it lateral, inferior, or septal, or interior? 2, 3
Lateral.
AVF. 2, 3 AVF. The ones that make up the corner of this graph.
Inferior.
Yes. So 2, 3 AVF is inferior. Thus, we're not done because we have other leads that are affected. We have leads V2, V3, V4, V5, V6. We said that V1 and V2 is septal, but only V2 is affected, and V1 is normal. So this is not septal, okay? Like, let's look at V3 and V4. They're both affected, so this means this is an interior MI. So right now we said inferior and interior MI, okay? Inferior-interior MI. And then V5 and V6, we would not consider them that much because it has to be a part of the lateral group, which is leads 1, AVL, V5, and V6. So this MI is inferior-interior. Okay, MI. Okay, so right now we're done with MIs. The next part is going to be your AV blocks. We have 3 types of AV blocks. AV delay is demarcated by what part of the ECG?
QRS segment.
No, the AV node delay. We said the P wave is atrial depolarization.
PR
then-
interval.
PR, yes. Did you say QRS or did you say PR?
No, first I said QRS, but then it's PR.
Oh, okay. Okay, so it is the PR interval. So the PR interval is what describes or represents the AV nodal delay. So if this PR interval is prolonged, then we could say that there could be possibly a block in the AV node, making this PR interval longer. So when we talk about the AV block, we have 3 degrees. There's a first degree, then there's second degree, and then there's a third degree. So first degree is when you only have a prolonged PR interval, and that is more than 200 milliseconds. 200 milliseconds is basically just 1 large square. So you can memorize either of which. Do you guys want to take a break or should I continue?
No, it's fine. You can continue.
Okay. So first degree is when you have a prolonged PR interval, okay? Second degree is when it's a bit worse, and the block is much worse. We have 2 types under the second degree, type 1 and type 2. Type 1 is not only that you have prolongation of the PR interval, but it's progressing. Meaning in the first PR interval you look at, it's like, let's say 2 large boxes in duration or in distance. And then you look at the next PR interval and it's like 3 large boxes. And then it's 4 large boxes, but it's progressively prolonging in distance or in the time that it takes. For this, you would consider a type 1 AV block. One thing that you should also like focus on is that not only does it have the prolongation of this PR interval, but then it continues prolonging and continues until one of the heartbeats drops, so that a normal P wave, which is the atrial depolarization, is no longer connected to the ventricles. So you have a normal P wave, but no QRS complex, meaning that the AV node is not conducting this electricity to the ventricles. And that is why you do not have a QRS complex or no ventricular depolarization. But this is Mobitz type 1, second degree. So two things to remember about this second degree type 1, which is progressive lengthening of this PR interval and a dropped beat. Mobitz type 2 is a bit more severe when you compare it to type 1. In this one, you have a single or intermittent non-conducted P waves without QRS complex. The PR interval is it's constant, but sometimes you have P waves and no QRS complexes. So there's no progressive lengthening. It's just constant PR interval, constant PR interval, constant PR interval. And then you have a P wave, but no QRS complex. Mobitz type 1 is when you have PR prolongation, followed by more PR prolongation, followed by more PR prolongation, and then suddenly a P wave, a normal P wave, thus no, it's not directly followed by a QRS complex. It's going to come much farther, okay? But this is second degree. Lastly, third degree. In third degree, there's complete block of the AV node. What does that mean? This means that the AV node is no longer conducting electricity from the atria to the ventricles. So the ventricles are completely acting by themselves and the atria are completely acting by themselves. But you see random P waves with random QRS complexes that have no association with each other. Let's take a look at some examples of that. So if we take this ECG is a bit different from the previous graphs that I showed you, but it has the same 12 lead ECG. So we have lead 1, lead 2, lead 3, AVR, AVL, AVF. And then on the right side, we have the chest leads, from V1 to V6. If you guys take a look at lead 2, which gives you the best description of these waves. Let's take a look at this one. QRS, and then a T wave, and then a P wave. And then there's a long distance between the P wave and then the QRS complex, and then again T, and then P wave, and then a long distance. Two things that you should notice. Is the P wave present? Yes, good. Is the PR interval prolonged? Yes, bad. Is there a QRS complex that follows every P wave? Yes, because if you look at this P wave, there is a QRS complex here. And if you look at the P wave, there is a QRS complex here. When you ask this question, is there a QRS complex that follows every P wave, you're basically just asking, is this electrical impulse reaching the ventricles or is it not? So if we only have PR prolongation, what type of AV block is this?
Type 1.
Exactly. So this is a first degree AV block. Okay. So this is a first degree AV block. Next question. So if we take, let's say, this one, first part. Okay. Let's focus on this one. So we have the P and QRS complexes. Are there P waves? Yes, we have P waves. The second question that you should ask, is the PR interval prolonged? You check this one, you check the second one. Yes, and it's progressively prolonging. And when we say that it's progressively prolonging to a point that you see a P wave with no QRS complex, what degree and what type of AV block do you think this is? Progressive PR prolongation followed by a beat drop is what type of AV block?
Type 2.
You mean second degree AV block?
Second degree, yes.
what type of second degree? Is it type 1 or type 2? So this would be second degree type 1. Let's go back to the box. Second degree type 1, which is also known as winky back, has progressive lengthening of the PR interval plus a beat drop. Type 2, on the other hand, has normal PR intervals, thus sometimes the P wave does not result in a QRS complex. We have P waves, but not after every P wave is there a QRS complex. Okay, so this is the second degree. So if we take a look at the second part. So we have the P wave here. The PR interval is normal in the first beat. And then we have the P wave here. And then there's suddenly no QRS complex. And then the P wave here with a normal PR interval. And then another P wave with no QRS complex. And then another P wave with a normal PR interval. The two things we can conclude from this second part, that we have constant PR intervals, but sometimes we have no QRS complexes. So what degree and what type of AV block is this?
Second degree and type 2.
Exactly. So this is second degree and type 2. Let's go back to the square, to the table, just to reinforce this. So first degree is when you have just a prolonged PR interval. Second degree, there are two types, type 1 and type 2. In type 1, second degree AV block, you have PR prolongation that's prolonged, that's progressive, followed by a beat drop. And then in the second type of the second degree, you have a normal PR interval that's accompanied with an absence of the QRS complexes sometimes. And a third degree is just basically when you have random P waves with random QRS complexes, with no any specific sequence. Let's take a look at the last part. We have a P wave, which is good. We have a normal PR interval. And then we have another P wave with no QRS. And then another P wave with no QRS. And then another P wave, but there is a QRS complex with a normal PR interval. And then another P wave with no QRS. What do you think this is? So since some of the P waves are actually conducting the electricity to the ventricles, this is most likely a second degree. Why is it not third degree then? The reason why that is because if you look at the P waves, some of the P waves are actually followed by a QRS complex, meaning that there is some electrical impulse that is passing through this AV node. If, for example, we have an ECG with a P wave and another P wave and another P wave, and then suddenly a random QRS complex with no preceding P wave, then this is what you consider a third degree block. Okay, for this one is just similar to the second part, and that will be a second degree type 2. Why is it type 2? Because it has whatever PR intervals that are there are normal, they're not prolonged. And the second thing is that sometimes you have no QRS complexes. When you have those two parts, that will be considered a second degree type 2 AV block, okay, which is more type 2. Let's take a look at this one. If we look at the LED 2, which is the rhythm strip, which is going to help us see the waves in a much better way. You see that this is a P wave followed by QRS that's for some reason facing downwards, and then a T wave, and then a P wave, and then a QRS, and then a T. So we want to focus on the P wave. So this was a P wave, this was a P wave, and then we have a P wave here with a very long PR interval followed by a QRS complex, and then T wave, and then a P wave with a very short PR interval followed by QRS complex. Then we have this as a P wave followed by a very long PR interval, and then this is the second P wave. It's very random, so this is most likely. Okay, but this is most likely. What do you guys think this is? Since the QRS complex is, to start thinking of it something that more of a prolongation of the PR interval with a sudden beat drop. Because if you look at this, there's a P wave, but no QRS complex. So this is most likely a second degree type 1 AV block. Okay. And then this one, you have random P waves and then a QRS complex that is not preceded by a P wave, then you think of this as a third degree block. Okay. Now, back here with irregularly irregular RR interval, they're either going to give you this in the question, or we're going to figure this out by analyzing the rhythm in the ECG paper. So if it's irregularly irregular, just know this is atrial fibrillation. That's all you need to know. So this is an example. How do you know the rhythm? You look at the rhythm strip. This is lead 2. You look at the RR interval, which is basically the interval between the R waves. So this is an R wave. This is an R wave. We have 2 large squares here, and then like 1.5 large squares, and then suddenly you have 4 large squares, and then here you have 5, and then here 3, and then 2, and then 4. So there's basically no sequence. If there was a sequence, you'd call this an regularly irregular, but this one is an irregularly irregular. So this is AFib. Okay, so this is ECG paper or atrial fibrillation. Ventricular fibrillation is basically a fast heart rate, which is ventricular tachycardia, combined by absent P waves and abnormally looking QRS complexes. And you'll only be able to describe this once you look at the ECG. Look at this, it's a bunch of scribbling. If you see scribbling, it's most likely VFib, okay? Ventricular fibrillation. You cannot find out where the P wave is, you cannot find out where the T wave is, it's just a bunch of scribbles. So this is ventricular fibrillation. Bundle branch block. There's a left bundle branch block and a right bundle branch block. You can know what bundle branch is blocked by doing the cardiac axis. So if there's a left axis deviation, this means that there's a left bundle branch block. If you combine this with those things, look at that. So they're saying if there's no R wave in that V1, combined by deep S waves, okay, and a wide notched R wave. Let's look at this. So if you look at this ECG and you look at the led V1, they said that there are no R waves. So this is actually an S wave, and then followed by a T wave, and there are no R waves, okay? And the next thing that they said is that if you have deep S waves, which we can see right here, we have very deep S waves and no R waves, okay? And then if we look at the third thing that they said is that you're going to have some wide notched R waves in leads 1, AVL, V5, and V6, which are the lateral leads. Let's take a look at lead 1. If you look at, this is the R wave, okay? But it's very wide and it has this small notch here. If you guys can notice this. So it's a notched R wave. So those 3 things combined together is what makes up a left bundle branch block. A right bundle branch block, on the other hand, is described as this. So if it's a small letter, this basically is telling you that the R wave is small. So we know that this is what normal waveform looks like. This is a Q wave, R wave, S wave, and then T wave. They're saying here that there's a small R wave. They're gonna have Q and then a small R wave, and then S wave, and then suddenly another R wave. Okay, so S and then an R wave. So it looks like rabbit ears. But this is what they call a right bundle branch block. If you see this in leads, in the chest leads, which includes V1 to V6, you look at this and you find rabbit ears. So this is an R wave, S wave, and then another R wave, which is described as this. And this is a right bundle or branch block. Okay. Ventricular enlargement, LVH is equal to left axis deviation, or you can use this criteria. But I generally depend on this left axis deviation. What is this criteria? It's saying that there is changes in V5 and V6. Why is the R capital? This is telling you that the R wave is actually very prominent. And then you look at V1 and V2 and you find that the S wave, the S letter is capital, which means that the S wave is more prominent. So you have very prominent R waves and very prominent S waves. Let's take a look at this ECG. If you look at the R waves, they're very prominent in this one and in this one, and you have very prominent or deep S waves. So if you see this, you just know that this is left ventricular hypertrophy. And another way of finding out whether this is left ventricular hypertrophy is by looking at leads 1 and AVF. So the R wave in the left axis deviation would be pointing upward in lead 1, and in AVF it should be pointing downwards in the opposite direction. And it's not seen in this ECG. Okay. RVH, you can just see a right axis deviation or a dominant R wave only in V1 and a dominant S wave in V5 or V6. So if you look at V1, you have a dominant only R wave. S wave is normal. And then V5 and V6, you have a dominant S wave. Okay, so this is right bundle branch block. Last thing is a junctional inversion. If you see inverted P waves, this basically means that the source of this electrical activity is coming from the Purkinje fibers. And this causes an inverted P wave. Okay, so the normal P wave is facing upwards, but if it's facing downwards, this is what we call P wave. If you see this in the exam with inverted P waves, you just know that it's junctional rhythm. Okay. I think we've done enough questions. I don't want to take so much time from you guys, and it's already 11 p.m. If you guys have any questions, please feel free to shoot me an email or send me a text on my phone number. And please feel free to give feedback. I know that this session took a long time, but I was trying my best to help you guys get every single question correct on the exam. Inshallah, this helps you all. And thank you for listening.
Thank you. It was very helpful.
I appreciate it. Thank you.